Thank you for being here today. I'm Heather Gatney, and I am the coordinator of the CVFS webinar series. Our host today is Dr. Sabrina Hermosilla, research investigator at the Population Study Center at ISR. Sabrina is going to share her work on the CVFS COVID-19 Pilot Study, which was implemented in early 2021. There will be a Q&A session after the presentation. We ask that you remain muted until then. During the Q&A, you may unmute and ask your question, or you can submit a question at any time today using the chat feature. We'd also like to remind you that this webinar is being recorded. If you have any objections, you may disconnect at this point. And then a recording of this webinar and the slides will be available on the CVFS website. So all yours, Sabrina.
Thanks. I'm gonna see if this works. Can we see my slides? Great. Well, thanks for the introduction, Heather. So as mentioned, the title of this webinar is CVFS COVID-19 2021 Pilot. And not advancing. Okay. And I want to start by, as I like to start all of these conversations, with really thanking everybody who participated in the study. So first, thanking the study participants and the ISCRN staff, everybody who's listening to this webinar, either live or at home, recognizes that we've all gone through a lot related to COVID. And I think, especially when speaking about a COVID-related project, it's important that we recognize all the work people have done. I want to also start by recognizing our funding. The work that's presented has been supported both by NIMH and then also by a pilot project seed fund that we received through ISCRN. Through ISR. And then lastly, I want to start with some optimism. You might be thinking, okay, we're going to talk about COVID, we're going to talk about death, and you're familiar certainly with the huge outbreaks and waves in India. But I wanted to first start off with an image of resilience and positiveness. And so this is an image I found related to some work being done by the UNHCR, the United Nations High Commissioner on Refugees. And basically, as you can see, it says Nepal is essentially the first country in the Asian Pacific to vaccinate not just their own population, but also those refugees that they're hosting. And so I just want to start us off with that positive imagery as we go through. So what are we going to talk about today? First, I'm going to give you a very brief overview of what the COVID-19 experience has been like in Nepal to date, and especially focusing on the time before this study took place. Then go over our study design briefly, and again, it's a pilot. Then highlight some results. Specifically, we have a paper that came out earlier this January that I'll walk us through some of the findings and give people an idea of what kind of analysis and things can be accomplished with this body of work, and then talk briefly about next steps, challenges, things like that. All right. And it's too hard for me to note, sort of monitor the chat. So feel free to document your questions in the chat, and then we'll get to them at the end. All right. Okay, so let's start. So in contrast to the other one, this image, when I was trying to think of how to frame and understand what it was like, what it is like to be living in Nepal, especially all of us who are engaged in some kind of work, but at least I personally, and none of the core people who are based in the US have not been to Nepal since COVID has broken out, to have a sense of what's going on. And this picture sort of captures a lot of the different challenges we've had with COVID in general the world over. And so this is an image early on in 2020 where people were actually being essentially hosed down with disinfectant, which is not appropriate and not effective. And people, because of overwhelming social media outcry and other interventions, this practice stopped. And I think that's a nice little vignette for a lot of the different things that we've all experienced, in that people are they're trying to do their best with limited information and data. And then when they get it wrong, hopefully people can be responsive to the population bringing this to their attention. So before we get into exactly what happened, what's going on, let's think a little bit about Nepal before COVID-19. And I know we've talked a lot here about CVFS in general, but we haven't gotten too much into some of the health context. So here are just a couple very brief stats to get a sense of what the health systems were like ahead of time. So Nepal ranked 107th out of 195 countries from the Global Health Security Index. So clearly in the bottom category of it, although higher than it had been in previous years. Most of these are from 2020, and I have the citations at the bottom of the slides if you want. They've also undergone the epidemiologic transition. So basically from primarily infectious disease and early childhood high maternal mortality, now to the larger burden of diseases and more like non-communicable diseases and things like that. The life expectancy at birth in 2020, not including COVID, because those numbers aren't out yet, was 71.5. So just to give you a sense of sort of what we're thinking of. So now, what has COVID-19 looked like in Nepal? This is a figure, and I was joking earlier with Coulter that whenever we're showing these statistics, we have to take a lot of them with a grain of salt, because they all have different challenges, limitations, but these are sort of the best ones that we've been able to find that are sort of, the idea here is to not take or tease apart any little component, but more to get a sense of the overall wave and how Nepal has acted and experienced COVID, and I'll say in a moment, in comparison to the US, since I think a lot of us will have experience with the US distribution and waves. So Nepal has a population in 2020 that was estimated 29 million. So just to give you some perspective. And so here's an estimate of the weekly caseload. These are in thousands on the vertical axis. And so in 2020 to 2021, and you can see clearly the first wave, you can see clearly the second wave. And now, unfortunately, we're sort of in the middle, can we say, the second part of the middle of the third wave. I think it's too early to tell. Nepal seems to be a little bit behind as far as the US wave has crested for Omicron. Just to give you a comparison of the US, again, these are millions as opposed to thousands, but there's a huge difference in population size. You can see sort of similar crests of these waves for cases. So another thing we're obviously concerned about related to COVID are deaths. And so here is an image of the population and the deaths across the different waves, right? And you can see them spiking here in the 2021. And then here's a similar for the US. It looks fairly different, I would say, in the US, but in part because of a lot of differences between the contagion. And then finally, this is actually vaccines that were administered. And so in Nepal, with this smaller population, about 54%, and this is, I mean, I think these are 2-day-old statistics, so let's see what they take that with a grain of salt. But about 54% of the population has received 1 dose of a 2-dose vaccine, or is 41% are fully vaccinated, in that they would have 1 shot if it's a 1 shot only. That compares to the US, where we have about 76% have 1 shot, 64 are fully, and 35 are boosted. I wasn't able to find any evidence of boosting on a large scale in Nepal. And you can see in general, the vaccine came far later than it has to the United States for perspective. So that's kind of it. I wanted to keep it brief because we could either keep it brief or we could spend the whole time talking about that. And this is not, I'll show you in a moment what this is, but this is not a full epidemiologic study of COVID in Nepal. That's not what we sought to do, and so that's not what we were able to do. But I just wanted to give you some little sense of what's been happening in Nepal to date. So what did we do in this study? We had three primary aims. The first aim was to collect data on COVID-19, and here this is what we're talking about: the induced physical, social, and economic disruptions. So really, we knew that within the CVFS population, we didn't have sort of the capacity and weren't really sure what the value add would be to go out and say, actually give everybody rapid tests. Certainly when we thought of this, there were no rapid tests available. But we also sort of thought, like, that's not exactly what this group, that's not exactly what this specific skill set is that will be a value add both to the population, but also to the literature in the whole. So what we conceptualize that could draw on these strengths and could have a real value is thinking about these disruptions, right? So we all, especially in the early days in 2020, we thought a lot about infection and the impact on individuals, but we really wanted to look at what are the disruptions, irrespective of people have COVID-19 or not. Everybody sort of lived through these different levels and waves of lockdown, and what was that like for people? So that was the point of the first aim of this study. So a few things to draw your attention to when you're thinking about what I'm about to say next. This was household based. So we had originally hoped to do individual based for every adult individual in CVFS, but we didn't get secure enough funding to do that. So instead, our sample is really every household who participates or who is in the household registry, if you're used to that language. And we conducted it not in person as we often do in these studies, but rather in a phone interview. The second aim was then to take these new data and to integrate them back into the existing panel data sets. And so the paper I'm going to present later on actually did take some other variables. And the reason why this is stated up front and why this is important is because when you look at when I walk you through our measures, it's very, very brief. And in part, we were able to be so brief because we had these household identification numbers. So if we wanted additional information from a household level, we could connect it back to other sources of data. So we really tried to leverage that body of work and not replicate or have redundant items. This both obviously helped for respondent fatigue, it made everything go faster, and helped us maximize our resources. And then the third aim is one that we're still sort of working on, and we'll get into a little bit later with next steps. But then one of the really big pushes for this and why we really wanted to do this urgently is because we are tracking CVFS. We have ongoing studies right now, the household registry is ongoing. We wanted to take a little snapshot at this moment in time. Yes, to focus on COVID for sure, but also so that going forward for future studies, we could rely back on this material and we could look at some of these disruptions and at least have some measurement of them, right? And so that sort of duality of purposes for this pilot study is really important in our motivations. And so it's also important for us to think about as we go through. So what do we do? For our survey methods, we interviewed one adult member per household, as I mentioned, and they were selected to report on the individual household experiences. This process is the exact same process that was undertaken for the household registry, so the staff was used to it. And in fact, at times it was originally conceptualized that this would take place during the household registry calls, but that wasn't always the case. These were phone surveys, and they were conducted in Nepali using computerized assisted interviewing software. And there were essentially, and I'll get a little bit into the sample a little bit later, but right away you might be wondering, what is the phone coverage in Nepal like? Are people switching numbers a lot? What is that like? How does that then affect the sample and potential sources of bias and things like that? And so what we found, just sort of telling a little bit at the end and the beginning, is that actually of the households, only 80 didn't functionally have phones. 40 did not have phone, we didn't have any phone number, and 40 had phone numbers, but they changed or moved, or we weren't able to follow up with them after multiple attempts. So what did we measure? So all of these tools, when possible, were adapted from either existing tools that first we sort of looked in the CVFS sort of library of instruments to see what have we implemented in the field in the past with this population, then a little bit broader to see what's been done in Nepal, and then if that wasn't possible, we looked to see for regional or other instruments that have been used. And we haven't gotten to the point of archiving all this information yet, but if you would like any more information, feel free to email us and we'll be able to, oh, in fact, I'm not sure my email's on this, but I can make sure that it's available, or you can email Heather and she'll put you in contact with me to make that available. So some of the main domains. We did ask some demographic questions. I mentioned earlier that we connected to the household registry, but we did have some measures. So age of the respondent, their completed education. This was also in part just to confirm we were talking to the person we thought we were talking to, and then internet usage. We also were really interested in getting a sense of resilience of their, which speaks to psychosocial well-being. We used the adult resilience measure RESIVE. This asterisk, both of these asterisks, you see here and here, indicate that these scales have been used previously in Nepal. So we were not able to do a full sort of instrument level validation study, although we did do some minor internal piloting ahead of time. We looked at social disruptions through the multidimensional scale of perceived social support. And then around COVID-19 itself, we looked at people's concerns around COVID-19, disruptions to their life that they attributed to sort of COVID-19. We did ask a couple items on prevalence to try to get at who had tested positive and when and things like that. But in a moment, I'll show you that we had a very low prevalence. And so it was sort of before this larger second wave. So there weren't that many there. And then we also spoke to people about, besides just concerns, but also what was causing them worry. And then relatedly, and this is the focus of our analysis, what mitigation behaviors people were taking. So in general, in their household, what were they doing to prevent COVID? From an economic perspective, we were very interested in what kind of disruptions people might be experiencing. We used the household food insecurity access scale. We also looked at household livelihoods and disruptions from COVID-19, some of which have been used previously in Nepal and some of which we adapted. And education, not surprisingly, both for the children themselves and also for the influence of disrupted education on the parents and the household. We wanted to see who was attending, what changes they had experienced during the COVID-19 period, etc. So I'm going to go into a little bit more detail now on the COVID-19 measures. So for the COVID-19 concerns and disruptions, an example of a question we would have, is what do you think are the most important concerns for your household under the current circumstances? And these were the items that people could choose from: food insecurity, crisis, medicine disruptions of medical supplies, education, illness, livelihoods disruption, travel restrictions. And these came out of our review of the literature, what people had been doing to date, which the instrument was designed in 2020. So there wasn't a lot of published literature on this, but what people were saying and what we had impressions would be the largest impact to people's lives. For COVID-19 prevalence, as I mentioned before, we had self-reported. And then for worry, we asked for in the past 2 weeks, how worried have you been about being infected or someone in your household being infected in COVID-19? And they could respond across the scale. So the 11 mitigation behaviors that we asked about include avoiding a public space, avoiding crowded spaces, physical distancing, hand sanitizers, gloves, face masks, shields, things at home, isolation measures, these kinds of strategies that we're all very familiar with. So that's it. Now I'm going to give you a little bit of our results. So for data collection, we had all the regular approvals. We were required to have approval in Nepal and the University of Michigan. As you can imagine, this was a somewhat lengthy process, but we were successful in getting those. And data collection, the primary data collection that I'm going to speak to results to today took place between February 1st and April 30th of 2021. And that covered 2,678 households with a very high response rate. And I'm bringing you back to this image that I showed about 10 minutes ago, showing the weekly cases. And our study period is that yellow box here, right? And so it actually is in a dip. And unfortunately, by the time we got going, and the team did a fabulous job going as quickly as they could, but essentially this second wave that crested came, and we had to suspend operations because this second wave was, as you can see from a case perspective, was much larger than any previous waves and had large implications. And so we just felt necessary to stop all work for that period for staff safety and security. And so then the remaining households were surveyed after that. We have that information. We just haven't fully integrated and cleaned it and analyzed it yet. And for obvious reasons, we have to be very careful when we combine things together. So let me go through this paper, COVID-19 Worries, Concerns, and Mitigation Behaviors, a snapshot of Nepal during the first wave. And those are our co-authors. The statistical analysis that we conducted was a logistic regression model that sought to estimate characteristics that were associated with COVID-19 worry. We picked worry as one of the first ones because we thought it was something that, well, people think about a bit and have published some on, was sort of an untapped area, and we thought it could then address and be a launching point for future studies. These models assess the relationship between worry and then specific types of mitigation behaviors as well. And all the models that we'll show are adjusted for age, education, gender, ethnicity, and COVID-19 exposure. So let me walk you through some of the things we found. So first, COVID-19 worry was associated with an increased odds of mitigation methods. So what we have here on the vertical axis are the adjusted odds ratios. And on the horizontal axis, you have the various mitigation behaviors. So the first is basically any, so a combination of all of them. And then avoided crowded places, kept distance from others, used hand sanitizer, face mask, gloves or shields. Part of why we collapsed gloves or shields is because that was one of the mitigation measures that had the least rigorous evidence base as far as how effective that was at preventing transmission. But we wanted to capture what people's actual behaviors and thoughts were, irrespective of if they were actually heavily based in scientific fact. Worked on school or work mitigations. So did they stay home from school, change their work behaviors, and then isolation measures. So if an individual was symptomatic or tested positive. At this time, it was very hard to get tests. So it was really more on symptoms. Were they isolated? And how can we interpret this? So if we look first at this, avoided crowded or public places, those who reported COVID-19 worry, so those who said they were worried, had a 3.14 times the odds of keeping distance from others compared to those who were not worried. So essentially, if you were worried about COVID-19, you adopted more of these mitigation behaviors. The next primary finding we saw was that people with COVID-19 worry were also more likely to report specific pandemic concerns. And so the worry was sort of an overall global measure, whereas these concerns spoke to specifically what are you concerned with. So you're concerned about food, education, medicine, yourself or your family getting sick, disruptions related to work, travel, other or none. And across all of these, except for travel, those who reported more worry reported more concerns. So, I said it would be brief. What do we take away from that? What do we take away from those two primary findings? So the first is that we really need to work on enhancing public health mitigation messaging. So this study really provides a unique insight specifically into Nepal, but basically about the general mitigation strategies that people are employing and how public health messaging and informational campaigns should really focus on helping people realize perhaps, and this gets a little tricky and we had to be a little nuanced. We don't want folks to go out and get worried about COVID. We don't want people to increase their stress and anxiety. That is certainly not what we're saying. But that people have a healthy understanding of their risk profile and then take that and translate it into increased behavior change activities. And so that's really sort of the triggering event. So that understanding that people individually are motivated by their worry, motivated by their concern, and that that's associated with the behavior changes of mitigation measures. And that public health messaging really needs to understand that and take that home when they're translating their messages. So that was the first paper that we did. We have a couple other that are in preparation, but I want to spend the next little bit, maybe about 5 or so minutes, breaking down some of the challenges. I dropped a little hints along the way, but I think you all probably are coming with an understanding of some of them. I want to walk through some of them together, and then we can get to question and answer and go through any that I didn't address. So first, the funding was very challenging for this. It's sort of easy and cliche for researchers to say that funding is always a challenge. Getting funding for this type of study in Nepal related to COVID is interesting because we sort of slipped between the cracks a little bit insofar as we weren't exactly eligible for humanitarian resources because, especially early on, the impact of COVID-19 was not large enough, was not bad enough, was not high enough, the caseload, the deaths, etc., which just objectively speaking is good, right? We never want that to be the case. But on the other hand, we are sort of struggling with trying to secure funding that then leverages it to another option, to other larger populations and things like that. But we were able to get some funding, and if this is an interesting topic to you, and partly why we really wanted to highlight this work here, is we are actively trying to build new proposals, and so if that's something people are interested in, we can get connected on that. We had some challenges around the design as well, so we were very clear what we didn't want. We didn't want to take a subsample of the CVFS population households, let's say. We didn't want to say sample 10%. You could say we could do like a flash survey of that, or 5% or something like that. And partly why we didn't want to do this was for the second sort of underlying motivation of this work. So the first is to get a snapshot of what's going on with COVID and the disruptions. But the second is that this is going to be placed within the overall panel study. And we thought we would be doing a disservice to future researchers, to future inquiries, if we only say had this variable in, or these hosts of variables in 10% of the households, right? We really thought that that might almost be such a disservice, and why are we doing it, right? Because clearly this is not, this was not a needs, rapid needs assessment that had programming attached to it or something else like that. There was no output in that regard related to getting like a quick flash survey of it. And so trying to get that design just right so that we could address or could reach out to every household within the CVFS population while staying under budget was a real challenge. Similarly, you had some challenges with data collection, and so we did phone interviews, which the staff had done in the past, but this was, also a little bit challenging under the constraints of COVID. And I already gave Deirdre a little warning that we might request some more information about some of these details if you all have questions, but just understanding that I think I'm hesitant to use the word sacrifice because I recognize a lot of the ISCRN staff really gain, or at least have communicated to us that this is their job, and they gain a sense of responsibility and purpose through doing their work. But managing that and understanding the power imbalance and things like that when we're asking people to do certain studies, certain data collection activities in this environment, that there's a whole host of challenges that we had to address to that and be very thoughtful and make sure that everybody stayed safe, the participants, the interviewers, from things you may say, a phone interview, well, isn't that sort of the most physically distanced data collection mode you could have? And on one hand, you're correct, but on the other hand, where are those people where are the ISRN staff staying? Where are they getting access to their laptops, their phones, their things like that? All of these considerations had to be taken into consideration. And I mentioned earlier the suspension of data collection for that second wave. And there's really, not much we could do about it. But it's just important for us to think about later analytically how and what methods we can use to compare the two, because the spike of the second wave was so much higher than the first had ever been. And the time since the wave was also much shorter, that the recall periods in the first primary data collection, individuals who were reporting on their households would be reflecting on a period of relative low contagion, relative low case count. Whereas after the second wave, they would be reflecting back on a period of high uncertainty, high instability. And so the two timings are very different. Spoke a little bit about the phone coverage issue. Also, ISCR staff is very, very, very diligent. So most of my research experience has been in humanitarian settings where we do the best we can and have really high expectations, but still after a period of time, you just say, I can't reach that individual, right? And I think ISCR and staff reached out so many different ways because they have different ways to communicate with different households. They really try to find a phone number, find any way to communicate with this household that they could. And that ended up being time intensive. And we have very little missing data because of their efforts. But just when thinking about the whole thing, those last few took a lot more time and energy than the first majority. And I alluded already to some of the typical modifications. One of the ones I wanted to flag was related to housing. So because the staff doesn't have the possibility on a whole, like many people who, if you're listening from the US, this is my apartment, I have wireless, I have internet connectivity and electricity and things like that. That's not the case for most of our staff at ISCRN. And so they did have to come in, and because it is a campus-like environment, there was the ability to have residential staff there. But that means time away from their families. I think it was 4-week rotations. Deirdre, I'm gonna flag for you the exact specifics of that, and it wasn't the whole time, but really, imagine this took place before there was widespread general testing, certainly before there was any sense of rapid testing. And so really the only way to ensure that people were kept safe was to have real genuine, quarantine ahead of time. And then really not just the interviewers, not just those things, but the rest of the staff, people who, who have to take care of trash, laundry, food, things like that. There's a whole lot behind this that we might not think of when we're thinking about, oh, it's just a phone interview. I won't go to you yet, Deirdre, because I'm sure people might have questions, but thank you for turning your camera on, because I'm sure people will have questions about that. So those are sort of the high level challenges and limitations. I really wanted to make sure we were clear and transparent about when we're taking this information into consideration. And that's basically it. I said it would be short. I hope we have some interesting questions that we want to go over later. So I gave you a very, very brief feel for COVID-19 in Nepal, went through the overall study design, and then specifically of this one, our first paper, gave you a sense, hopefully, of some of the findings and how you can take some of the variables and items that we asked about and apply it to different questions, and then left with next steps in some of our challenges. So as we started with something optimistic, I'd like to also end with one. And so this COVAX has been challenging, I think would be an understatement. But this is a recent image that children are starting to be vaccinated in Nepal as well. That's one of those sort of asterisks whenever you see vaccine coverage, is every country has different eligible populations, but children are starting to be vaccinated in Nepal. And so that hopefully will help mitigate any negative impact of future waves. And so I wanted to end with thanking our funding again, but also explicitly thanking our collaborators. So I'm the one presenting to you today. Thank you for inviting me, but this is on behalf of Emily Trelevin is part of this team, Deirdre Gamiri, obviously, Bill Axon, myself, and Melanie Ascari. You may not be as familiar with her, but she joined us as a research assistant throughout this work.
Hi, Sabrina. This is Nick Shakat-Levy. I'm a PhD student at Princeton, also hoping to work with ICERN on climate change adaptation in Nepal. Thanks. That was a really great overview of the work that you've done, and really interesting to hear about how the staff has had to manage the COVID challenge. One question I had is, do you have a sense, either like while you're developing the survey or through the results, about any correlation between like the COVID worries, like the worries about the specific aspects of people's lives, and any impact that you were able to measure, like if they actually had an impact to like health or livelihood, like how that correlated?
Yeah, that's a great question. So essentially, if they were more worried, had they had a larger impact? And I guess the question, the way I can say is, we haven't looked at that yet. So that's why we have those in there, but we haven't looked at that yet. And we really basically have looked at this paper that we're presenting, because it sort of took us all this time to get the data and clean it and look through things. And so we wanted to give you something as a teaser. But yeah, these are sort of some of the questions that we're hoping to dive into a little bit more.
Great, thank you.
I was just wondering descriptively if you have a sense of kind of what of specifically some of these mitigation strategies you're talking about, like how frequently were people adjusting their work schedules and their school schedules? How much of this, if you have any sense of like, was any of this by people motivated themselves or institutionally put down? If was that like a moment of conflict or strain for people, those differences?
Yeah, that's a great question. I can try to answer the middle one, but you're getting at exactly what we are trying to understand a little bit better. And one of the things that I sort of didn't really flag here, but we flag in our paper and have had a lot of discussions about, is tracking sort of the local and regional restrictions, right? Because many people aren't going to just start wearing masks or start doing things on their own. Oftentimes this is because they're required to, or offices close because they're mandated to close for in-person and things like that from regional offices. And so there were periods where schools were certainly closed and businesses and things like that. It wasn't constant in the year 2020 to 2021. It varied a bit. And certainly in the group after that second wave, all of that recall period is a period where people were highly restricted. But I will pass over to you, Deirdre, for a moment. But I will say, even in that context, a lot of this population isn't used to going into traditional office spaces for work and things like that anyway. So some of them, even under restrictions, it was more the schooling that impacted them perhaps, or some sense of the markets. But other on their day-to-day experiences, if they're involved in agriculture or something like that, would be less disrupted. Deirdre, do you want to?
No, I think you cover very well. The only thing I want to add is it is not only the only source of COVID-related data in Chitwan Valley. We have other two studies. Reliam study that is mostly focused on migration to Gulf. So we interviewed migrant with that instrument. So we have some more source of data to get those kind of descriptives. And then we also, it's a different sample, but within Chitwan Valley, Family also has added a section on COVID, and we do have information on those data set. The Family data is still, we just completed the data collection and is still in a cleaning stage. But if we want to, work on those, we could definitely make available as time goes by. And in terms of in terms of disruption in their work, employment, or education, yes, we do have those questions in our instrument.
And I was going to actually, Deirdre, the other source of data is the household registry.
Yep.
So that continued, and if you're wondering why we didn't ask more things about like death or something like that, is the household registry, the ISCRN was able to continue to field that. And so in theory, over time, we'll also be able to look at some of those demographic transitions and explore this time period through that lens as well.
That's true. Yeah.
I will say though, I've at least given a lot of thought to some and the challenges of doing qualitative work around this sort of motivation, that you were bringing up earlier, Sara, about like, is there a tension between their own behaviors versus what are sort of community mandates or norms versus the government, and we don't have anything like that yet, but I think that could certainly be something. And it's every time we talk about either this study or thinking about future studies, the optimist in me wants to say this won't be an issue in a year or two, but the realist recognizes that with low vaccine coverage and mutations, that there will be some continued disruptions from this. And certainly in contexts like Nepal for the future. So some of these qualitative questions, especially around motivations and what got people to make changes or things like that, could still be really salient.
Yeah, I think your questions on resilience too are going to be really interesting to look at. And, you think about, but I mean, like, if we're not doing a big epidemiology, what are the big important questions we can be answering about this? And I think, contextualizing those kinds of like softer outcomes is something that the CVFS can probably do quite well. Like, how do people really feel about these experiences, controlling for everything we know about what their household is like, what their previous mental health status for many of these people is like. You see Coulter, maybe even like what their, DNA is like, I think that could be really interesting. And thinking about what is social isolation, what does isolating yourself mean in a place like Chitwan versus a place like Canada. Like, I'm not allowed to go in anybody's house right now, so I don't know if there were rules like that in Nepal, and how that would have translated into how people were living daily lives differently. I think those are kind of really interesting questions that we could get at, especially given how much information we have before.
Yeah, we did. I'm just going to respond unless I'll pass to you in a second, Coulter, but we did start some. We did take this and attach it to the CD data set. And did start to explore some questions related to sort of past symptomology and if that predicted mitigation behaviors. We paused that for a little bit because we want to be very careful and make sure we're asking a question that isn't misinterpretable. Especially in early stages of infectious diseases, things like, oh, people with a history of depression, employ fewer mitigation strategies, so they're the cause of COVID transmission. Like, we want to be very careful and thoughtful about those kind of unintended interpretations of our work. But that was actually the first, after taking this and grabbing some variables from the household registry for context and things like that. The CD data set was the next one that we worked with. But jump in, Coulter.
Oh yeah, no, I loved hearing this. Actually, Sarah, my brain went to a very different place, which was most of my work, in graduate school was on the ideational side, right? Of what drives people to make fertility choices, or, and suddenly, like when all of this was being talked about, I was like, oh, not that this group wants to hear anything about developmental idealism right now, but I started to think about decision making and who says what and what do they already believe about, like, what counts as modern and things like that. And I think there's actually something pretty unique here, because Sarah's right that, like, not only you have the nice background measures, but, like, when it was first started, there were a lot of ideational measures that are actually probably pretty powerful in terms of being able to predict who is it that acts one way versus another way, uses one mitigation strategy versus another, that are not rooted in kind of classic epidemiological methods, that are more social psychological, probably come from a pretty different framework on what drives people to take to use one type of fertility or contraceptive use. Sounds strange, but actually there's a lot bigger processes, worldviews going on behind that. And the only other thing I was going to say, Sabrina, is hearing your challenges with collecting data as part of this is there needs to be a journal where all of us who have tried to collect COVID data during COVID can, like, just write down our experiences, if only to, like, vent for our own mental health, but also to, like, help for the next thing that we have to collect on, because it has been the most bizarre data collection experience I've ever had in my life.
Yeah, I would say I would echo that. And so all of my data collection experience basically before coming to CVFS has been humanitarian settings. And so I did have 2 rounds of data collection in Lebanon and Uganda at the same period. And I think that experience, I'm going to contrast it to CVFS in a moment, really highlights one of the uniqueness of this era, insofar as the restrictions seemed very heavily based on the US universities and institutions. In Uganda, for example, I was the one who was like, no, no, we need to have more restrictions. We need to have smaller groups because well, I'm not, I don't want to pontificate on the because we're recorded, but just first of all, the different constellations of protections and the power those different groups have and how they interface with each other. Anybody who's, done an IRB proposal where you submit them both sort of concurrently, yet, say, well, the local is primary, but also the university is primary. All of those challenges in sort of regular work, they're challenges that sort of are a little bit tricky. And Heather, I know you live this a lot too, but in COVID, it was like a magnifying glass. And then you add the layers of all of the researchers, often in humanitarian research, there's somebody who leaves the setting and has every 6-8 weeks, you have mandatory rest and relaxation, who goes someplace else, who does something else. But in this setting, nobody could do that because it was a genuine pandemic. So everybody was dealing with all of the disruptions, delays in different settings, and then trying to communicate with US-based groups, IRBs, what the local realities were, and how also we have an obligation to do research, right? Because the easiest thing would be to just sit home and do nothing, but then we're systematically erasing those voices and those experiences from the literature. And that's inappropriate as well. So if you want to start the journal, Coulter.
Yeah, yes and no. Mostly no.
I don't want to put you on the spot, Heather, but I don't know, you did some of the IRB stuff here. Did you have any thoughts to that point, especially for folks who maybe are students or who haven't had that experience?
Yeah, working with the IRB at this point in time, so this would have been late 2020 when we submitted the application, there was absolutely no in-person interaction with subjects allowed whatsoever. So in a way that made things easier. We knew that we had to do a telephone mode and that we needed to do consent by phone without signature. And in some ways, I think the IRB was allowed for us to have that level of consent when so often we're asked to obtain signatures and document consent in the field. So I thought it was great that they offered that flexibility given how important this study was. I actually have another question. So this is a pilot study, right? I was wondering if you have plans for a follow-up, or I don't know, maybe you want to call it the main study, but the resiliency measures, I think, are really interesting, and I would like to see how those change over time.
Yeah, I really, the two things, so we have plans, we don't have anything under submission. Nothing's going in next week on this. But one of the big, if we call it a main compared to a pilot, one of the main changes I think that would really be helpful would be to get it to be individual. Even if that means you only get the adults and you have all of those challenges or whatever, but a lot of these questions, this reminded me of what you asked earlier, Sarah, about and Coulter a bit about motivations. We were really concerned and couldn't really do much about the fact that we are using a household respondent to report on everybody in the household and all that means, right? So when they're reporting on these are the behaviors that my household is engaged in, you know, keeping distance from others outside the household. Well, maybe that's what the rule is, but I don't know if every adolescent is following that rule, right? Or I don't know if every, you know, I don't want to just pick on adolescents because that's what I'm writing about right now, but I don't know if every person in that family is as compliant as the person we're asking is. Or, you know, how that sort of social desirability to tell people that they are being more compliant. I think at least in the majority of the interviews that happened before the second wave, because transmission was so low, I don't think we had too much of that, like, oh, I'm going to tell people I'm doing something, that kind of social desirability, whereas I'm not doing it because the risk was seen as so low. It's just interesting. And in theory, like, my dream would be to do this more frequently, right? Because each one of these snapshots is going to be so dependent, as it should be, on the base transmission and your understanding of the base transmission, right? And insofar as that information is made publicly available or you're aware of it, right? Because we're not saying when there are very few cases that people should be doing all of these things and should be socially isolated. So there's also those interesting analyses that we'll have to take into consideration. So the one of the reasons, which I said before, that we wanted to do this is to pique people's interests and to get people thinking about this so that we can do another round or two. And that we can build on this. And if we do it at the household level, that's fine. Or if we're able to break out into individuals, we can do that as well. And I think the team at ISCRN has managed and broken through a lot of the challenges already. And so there'd be a lot of efficiencies gained in that.
I think we're at just about 3 o'clock. Thank you so much, Sabrina.
Sure. Thank you, everybody, for coming.
Thank you.
All right. Bye.